Okay, thanks. Thanks everyone for joining. Let me just move this over here. Okay, there we go. So this is the Incarceration Prevention and Reduction Task Force Joint Behavioral Health and Legal and Justice Systems Committee meeting, and we're meeting here at 11:30 on September 16th, 2025, and we are in a Zoom environment here this morning. Before we begin, I'd like to acknowledge that we are gathered on the traditional and unceded territory of the Lummi Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us here together today. And please join us in uncovering such truths at all public events. So I'll go ahead and bring this meeting to order. We're at 11:33. We've got several items today that are, I think, of great interest. And the first one is the Whatcom County Sheriff's Peer Support Team, and this presentation will be conducted by Corrections Chief Erickson from the Sheriff's Office and Dr. Michael Early. And go ahead, the floor is yours.
Excellent, thank you. So first of all, I am going to defer to my partner, Lieutenant Jason Carr, who's going to be a chair. He was having some difficulties in his office getting connected, so he's just sharing space here with me, and he is going to do the presentation. And Jill, I believe you have the materials on your end.
I do. I will share those. Just one moment.
Thank you. Get over the desk. I'm good.
There we go. Does everyone see the presentation here?
We can see it. Yep.
Perfect. That's the last page.
There we go.
I guess we're going backwards. There we
There
go.
you go. Hey, got to start somewhere. That's great. Of course, mine. Okay. Hey, thank you for, first of all, inviting Dr. Early and I to meet with everybody, have a conversation, and just kind of showcase our Whatcom County Sheriff's Office peer support team. Unfortunately, Dr. Early isn't available today. He splits his time among multiple different agencies. Right now, he's currently working with WSP in Anacortes. So we collaborated on this presentation and put it together. And so I'm going to be the one presenting it to you today. My name is Jason Carb. I'm a lieutenant here with the Whatcom County Sheriff's Office. I've been with the Whatcom County Sheriff's Office several years, but just for some historical context, I started my policing career roughly 32 years ago. Did some policing work when I was in the United States Marine Corps as a military police officer and as a presidential security specialist. And then I went to work in the Whatcom County Jail after I got out of the Marine Corps. I worked several years in the Whatcom County Jail, and then I moved up to the Hill and became a police officer with Western Washington University Police Department. And then several years later, I moved back to Whatcom County, and I've been called Whatcom County my home since. It's been a little over 20 years, and I've stayed here. So I just provide you a little bit of historical context with me as we move through the kind of showcasing our peer support team. Next slide, please. All right, so just a quick brief history of Whatcom County Sheriff's Office peer support team. For many years, we didn't have a peer support team. We essentially used EAP, the Employee Assistance Program, as kind of our support. When folks needed mental, emotional help, we referred them to those resources. But in 2019, the state provided us some funding for what we call the Cortico app. All the deputies have that on their phone. And we started a peer support program in 2019. The peer support program was very different then than it is now. It was more, I would say, reactionary, meaning people that essentially wanted some peer support, there was a list of people and you'd reach out to them if you wanted to talk with them. We certainly do that now, but we are a little bit more proactive with our folks' mental, emotional well-being, and we reach out to them and talk with them. So 2024, we kind of reimagined our peer support team here at the Sheriff's Office. In 2024, 2025, we brought aboard Dr. Early. Dr. Early is a psychologist, and he helped us bolster our program. And we started basically by reevaluating who's on the team and what we wanted our team to look like. And so we did that by essentially the grassroots, going out to lieutenants talking to sergeants, sergeants talking to deputies, and getting names of folks that we thought would be good in the peer support capacity. And we came up with several folks, and including in the jail, and we created what is essentially our peer support team currently. This was great just because it provided some kind of instant credibility and legitimacy to our program. You know, we were putting people in the peer support program that that's who deputies felt like they would want to talk to if they needed to. And so it worked out really well. Next slide, please. Our mission at Peer Support is, I won't read the entire thing to you, but it's basically to identify, recognize, and respond to our first responders when they're experiencing some sort of emotional, moral, mental health struggle. Our vision of our peer support team is to prevent, lessen, reduce, and be a supportive engagement that helps reduce the impact of stress of our first responders. And then our authority is, if you're not familiar with it, is under RCW 560-66A. And I've put it there, and if you're interested, you can certainly maybe jot that down, or we can provide this slide to folks afterward so that you can go in and kind of look at what the law provides as far as peer support services and what we can offer, and statutorily how we can do it. Next slide, please. This is kind of the dynamic or the makeup of our current peer support team. We have 20 members total. Dr. Early is our embedded licensed psychologist. We have 2 lieutenants, myself and Lieutenant Boss from the jail. We have 2 sergeants, and 1 from patrol and 1 from the jail. And we have 12 deputies from patrol and from the jail. And we have 3 support staff. So that makes up our caveat, or our cadre of 20 supporters. Next slide, please. So on that previous slide, when we were talking about authority, in order for us to be active and engage in peer support, we have to meet some criteria. That criteria is that we all have to be trained, and that we have to be designated. So it took a little bit for us logistically to get 20 different people trained up in how to properly do peer support. But we were able to do that with Dr. Early and with the assistance of Bellingham PD's peer support team. So all of our team is trained up, they're operational, and they're working. And they're busy. We have ongoing training that we're going to be doing. Our peer support team was very active in the most recent shooting involving the Lummi officer. So we found out a deficiency in our training there, meaning that we couldn't conduct critical incident stress management training because we'd never been trained in that. We were trained in kind of a one-on-one scenario peer support, but not on the critical incident stress management side of it. And so we applied for and got a grant from the Washington County's risk pool, and we're sending 4 people in October to that training. So we'll have 4 people that will be trained up in that and ready to go, which is great. We will have ongoing training biannually for all peer supporters. And of course, the topics and the presenters will be determined. Next slide, please. So what do we do and what does it look like? This is kind of the meat and potatoes of peer support. So peer support works off the county network. We have confidentiality and privileged communication. And peer supporters are active in typically one of 3 ways. They get notified via a critical incident. Maybe it's a use of deadly force. Maybe a deputy is assaulted, or like I said earlier, we were involved in the Lummi Nation officer-involved shooting. Via that critical incident, we do check-ins on people that we think need to be checked in on, just to see how their headspace is, if they're eating, if they're doing these things that they should be doing. Sometimes peers in our agency will have some contact with folks and realize, hey, maybe he should speak with a supporter because this was a really rough call. And so we get peer referrals. And once we get that peer referral, we send it out and we'll have deputies check with them and just check how they're doing. And then, of course, we also have self-referrals. When a person just feels like they need to talk to somebody, then they will reach out to us and we will do so. So peer supporters are ensuring that people are checking in with people, making sure that they're getting rest, that they're eating, exercise, and we're conducting follow-up to make sure that they've got what they need. We, as peer supporters, there's kind of a fine line where, we'll do one to 3 check-ins. And if we're doing any more than 3 check-ins, we're kind of referring that person to Dr. Early at that point. There may be something that is more pressing and they need maybe some counseling or therapy or clinician or something like that. So it's beyond the initial stages of peer support, and then it moves up to Dr. Early's realm of expertise. Okay, next slide, please. I see Wendy Jones is here, but does anybody else know who these 2 corrections deputies are? You can raise your hand. Anybody? Wendy, you can't answer. Okay. I don't see any hands raised, but I know Wendy knows who this is.
I tried to raise my hand. I know who they are.
Okay. So the last guy is in the back is me. And that's me in 1998, I think, maybe 1999. I'm not quite sure. And so I just want to take a moment and talk with you about a personal story in peer support. And and I think this personal story will really illustrate why we have peer support. So the deputy in the back is me. I'm Jason Carb, and the deputy in the front is Doug Radke. And Doug Radke, I worked several years with Doug Radke. I was when I worked in the jail. As I said earlier, I worked in the jail in '97 for several years. Clearly, I worked with Doug. Doug was a reserve deputy for a few years, but he'd had several years in the jail, and just a great guy. He could do everything in the jail. He could be a sergeant if he wanted to, but he typically ran the transport unit, which we had folks going to and from court and court appearances and out of county and whatnot. And so it's of no surprise, this is a picture of Doug and I here escorting a gentleman to his first appearance who was incidentally charged with murder. This was all happened inside, the first appearance was within the confines of the jail here. So I bring this up because unfortunately, Doug and I were pretty good friends. We actually walked to work together, or I rode my bike and walked home with Doug just about every night. And we developed a pretty good friendship and a relationship. And like I had said earlier, in 2000, I left the jail and I went to Western Washington University. And unfortunately, in 2001, as Wendy knows, Doug took his own life. And so Doug took his own life and by suicide. And I just think that if we had had a program like we currently have in peer support, how doing a check-in and having some intervention would have made a big difference in Doug's life. And I would like to think Doug might even still be with us today. So next slide, please. Unfortunately, at the sheriff's office, we experience a lot of trauma. And I'm not going to go over every specific thing, but in the line of duty, we've had several officers killed or injured, unfortunately, due to driving, due to felonious assaults, but also through suicide. Post-traumatic stress disorder is a very serious thing in our profession because we in the jail and on patrol see some of the absolute worst that is out there. And so there's some serious challenges in that. This program has created an outlet for using good cause to help people not go down that dark path. And it's also, the success, quite honestly, is measured oftentimes in the health of each employee, how productive they are, their tenure, their retention. These are all, some of them are intangibles. But what we have seen is the cup of some of our folks just overfloweth, meaning the PTSD has kind of caught up to them. And we've had several in the last few years who have gone out on early retirements that have been PTSD related. And so this program, when we reach out and we work with people and we try at the very beginning stages to use a good basis for intervention, we reduce that. And because of that, we're better for it. Next slide, please. So like I said, Dr. Early couldn't be here, but he wanted to envision that, peer support is like a rope in a net of overall wellness program, which we use to catch people when necessary. And I think that's a great analogy for just kind of what our program looks like. It's only one little thing in the myriad of things that we have that we can reach out to folks and help them and get them through whatever tough times they're going through and get them beyond that. So, next slide. This is hard in our culture and law enforcement culture. I told you that I've had several years on in law enforcement, and quite frankly, for most of my career, it's been like, hey, just keep your chin up, and this too shall pass. And that's not really the most medically sound way of dealing with some of this stuff, as I'm sure all of you can relate to. So, you know, it is changing our agency just because we're having deputies do check-ins on deputies, and they're like, what are you checking in on me for? For some of them that have been around several years, it's different. And that's why I say we're actually changing the culture of our agency in that regard. It's a good change, and I think it's kind of an expectation. So we're working through it, and yeah, that is this kind of the sum and substance of our peer support team and what we provide and kind of what we do. Are there any questions?
This is Brian Estes. I have a couple just quick questions. First of all, thank you. This was a great presentation. And I was just curious if you have any way to capture some of the, outcomes of this program in terms of reduced stress or, for example, improve staff, wellness or even retention. I mean, I don't know if you periodically do surveys of, the first responders in the Whatcom County Sheriff's Office, but I wonder if you can just comment on that.
Yeah, that's an excellent question. And I thought about that, and we're so new in this model of peer support. We literally, we put it together in 2024 and got the training in 2025 and became deployable in like May of this year. So
this is brand new, basically.
Yes, this is brand new. And but you make a very good point, because we need to be able to quantify the benefit of it, right? And again, some of that benefit is, people actually, coming to work or taking this sick time, or but that's a really good question. I don't know that I could answer it because we're so new to it.
Oh, of course.
But I do think that I will talk with Dr. Early, and I think there's a good way of probably doing that. Maybe a survey, or sending it out to our deputies and having them.
And I just wanted to make a comment. I'm involved with the National Alliance on Mental Illness as a board member here locally in Whatcom County. And I'm really glad that you mentioned that these are medical conditions. People who are struggling with mental health challenges, it's a medical condition. If you have cardiovascular disease, you see a cardiologist and you get medicated. Similarly, if you have mental health challenge, you may see a psychiatrist and receive medication as treatment. So I wholeheartedly understand the cultural maybe shift that is a challenge here, but I think the more we can talk about reducing stigma of mental illness, and that is a medical condition. These are not behavioral choices people make. It's a medical condition that requires treatment. So I really support that. You bring up that issue. So thank you. Are there any other questions from any other people on the committee?
There are a number of hands raised. Raylene?
Yeah. Thank you so much, Lieutenant Carb. I really appreciate this. I have had 3 people that I know that have committed suicide. One was the spouse of an officer, the other one was a son of an officer, and then the other one was a dear friend. So I know how PTSD can dramatically impact individuals and how hard it is. There's recently an article that was from North Dakota in the courts about jurors that were actually receiving PTSD, and how the state of North Dakota have passed legislative action to provide those jurors that have PTSD with mental health assistance. And I've noticed, as I've transitioned from the law enforcement world to the courts, that it's actually impacting my clerks as well. So we have clerks that see pictures of child molestation, rape, murder. And it's not the I mean, it's what the law enforcement officers have had to see in the field, but there's things that they can't erase. I've got one clerk that did her first murder trial and she came back and she said, really, I can't get rid of this. I can't remove those images. I can't unsee it. And we're supposed to be neutral. We're supposed to sit up there and listen to everything and keep our faces straight and, you know, all these things. And it's very difficult. So I understand it from the law enforcement side, but I think it goes further than that. It also impacts all of those working in the courts. And it's not just a murder trial or rape. It's also when you're having to remove kids from a home. I know that Lieutenant Carb is probably familiar with the writ of habeas corpus, when a family member decides that somebody has violated their custodial rights, and the judge signs an order, and then we have to take those kids into a courtroom. And once again, I have clerks in every court, in every hearing, and they're seeing that, and it's traumatizing. We have an employee assistance program for the clerks. And we make sure that they all have time available to get therapy when needed. I have a lot of clerks in my office that have that, so I really appreciate it coming to light and that it's necessary for law enforcement. But I think we have to go a little bit further than just the officers on the road, because it impacts a lot of us. So thank you so much for the presentation.
Thank you.
Yeah, Jason, I just had a clarifying question about one of your slides. The one that had some numbers on it in terms of events experienced by Whatcom County Sheriff's Office. And there was a number that said 134 suicides. I guess I made the assumption that was suicides where a law enforcement officer had to deal with that kind of a situation, because 134 seems like a high number for deputies having done that themselves. Or maybe it's a longer period of time or a broader scope than just Whatcom County. Can you just clarify that number?
Yes, I'm glad that you bring that to light. And I didn't speak directly to it, but there is a link underneath it. That's actually, I got that from the FBI's website, and that is law enforcement suicides in the past 3 years nationwide.
Nationwide.
Yeah, so it's not specific to the Whatcom County Sheriff's Office, but I put it on there because, you know, it's trauma, that unresolved trauma that law enforcement officers are dealing with, and you know, it's emblematic of kind of what's going on. So, thank you for the clarification.
I did just send the judicial news clips link to Jill to forward to those that are interested, but it does have a study about how some stuff affects people. It was a 2024 study. It might be helpful.
Thank you.
I've got a
Any other questions?
Yeah, I've got a quick question. This might be more for Sheriff Tanksley. It's sort of related, but not exactly. I'm just wondering. So yesterday, the Bellingham City Council voted to do a first and second reading on a 0.1% sales tax for a CJTC grant, so Criminal Justice Training Commission, and this would be pursuant to getting our 25% of our officers trained in crisis intervention team. Um, uh, so, and that's a 40-hour training is pretty significant. And I'm just wondering if the sheriff's office is going to be pursuing, or if I guess the county would be probably the better question, would be interested in pursuing that 0.1% sales tax. Now, there's also $100 million grant that's being proposed, or that is out there at the state level, that can be divvied up between multiple jurisdictions. So I'm just trying to understand that a little bit better. It's sort of pursuant, kind of in the realm of what we're talking about, but it's a little bit tangential. But I figured since we have folks on the call that might know that information, I thought I'd ask here this morning, or I guess this afternoon. Now it's 12.
Sheriff, do you have?
Absolutely, absolutely. So I have had conversations with the executive's office over the tax and the grant itself. Um, Within the parameters of that, you're right that there are certain things that the law enforcement agency has to do. For example, have 25% of their deputies trained in the 40-hour crisis intervention course. And then also there's a requirement to have all your investigators trained in gender and trauma informed investigations as well. In terms of the sheriff's office, the crisis intervention training course last December, we brought the Criminal Justice Training Commission here to Whatcom County and trained, I believe, a total of about 18 officers and deputies here in Whatcom County. That same course we're going to offer again this December. Once we complete that training, I'm almost positive that we're going to be over the 25% mark with having our deputies trained in crisis intervention. The actual tax increase, that's going to have to be a item that the council has to decide on. In terms of the grant, we plan on pursuing the grant as well, and that doesn't require councilmatic action. And lastly, I just want to thank Lieutenant Carr for putting on a great presentation. And I'll also add too that Dr. Early has been fantastic, and we were able to get him on board with grants. So we applied for 2 different grants, which got him on board, but that funding has expired. And that's one of the reasons why you don't see Dr. Early today. So we're looking for additional funding to ensure that he stays on board. And he's not only doing a great job here at the sheriff's office, but he's also doing a great job at Bellingham PD. He's doing a great job at Anacortes. So I'm just putting that out there that we need funding to keep this program going. Thank you.
Yeah, thank you, Sheriff.
Thanks, Sheriff. And thanks to Lieutenant Carr. I see we have Stephen Traff asking a question.
Yeah, so I attended the CIT training last December with the sheriff's office. We had Bellingham there, we had Ferndale, we had Blaine, we had Lummy that was there, and kind of to go off of Chief Carb's comments, it's good to kind of network with each department to kind of share resources because a lot of the law enforcement community deals with a lot of the same kind of traumas. And so knowing that connection can really help out kind of tapping into other departments. And I'm with US Customs and Border Protection, and we're really dealing with a lot of the resiliency, a lot of suicides, and the mental health issues. And so I'll be hopefully reaching out to you, Jason Carb, and maybe we can kind of coordinate together.
Yeah, please do. Please do. And I would say to dovetail into what the sheriff said about the CIT course, we are hosting the CIT course again here in December. We went through the Criminal Justice Training Commission to do that, and it filled up within a week and a half. And so we have like 18 people from the sheriff's office, I believe, that are attending that. And it's full. So the need is way greater than the resource. So CJTC is aware of this, and I spoke with the trainer about potentially offering another course, but they're trying to disseminate those resources throughout all of Washington State. So they will do it. I think it's the sheriff's intent to try and do this at least once a year, every year, to rotate through our agency, Bellingham PD, Washington State Patrol, and all the outlying agencies.
Okay.
Okay,
Any other questions?
I think we're good.
I just want to point out that, talking about mental health in a law enforcement circle is sometimes considered to be taboo. In addition to that, it's viewed in some circles as a sign of weakness. If you admit to having any struggles or challenges in terms of mental health, that's certainly not something that I espouse to, nor is it something that Lieutenant Carb does. But I just want to point out that it takes a particular person or persons to be involved in this work to make effective the body of work that these folks are efforting after. It takes the right personality. It takes the right person who's interested and engaged, because it is a real challenge sometimes in this arena to talk about mental health. And then, Brian, to your question earlier about statistics or being able to track the efficacy of the program, we don't have anything other than anecdotes at this point, but I can say for sure that we are getting routine referrals to clinicians and therapists through the program. And while I don't get to know the names, we're hearing that this is doing good work on a weekly basis here in the Sheriff's Office. So I'm very thankful for the program, and I'm thankful for this presentation as well.
that's really good, really good to know. I mean, that at this point, having just started a few months ago, that it's already having a very positive impact. And organizational cultural change takes time. Are there any other questions before we go to our next agenda item? Okay, well, thank you very much, Jason and Caleb. And I believe now we'll turn it over to Caleb to talk about the Work Center Reentry Demonstration Initiative Program.
We're just moving positions. Bear with us a second here. Thank you. So what I wanted to bring up is, this is kind of an ongoing topic of discussion for this meeting, is the Washington State Healthcare Authority is engaged with jails throughout Washington State to provide a demonstration waiver to allow for billing of services directly to Medicaid for people who are incarcerated. There's a lot of stricture involved with that. It's easier to say than it is to do, but the long story short on this is I've been interested in giving you all updates about where we are. We were one of the early adopters in the process. Whatcom County applied to be in cohort 1, along with, I believe, a total of 19 jails in the state to get the reentry waiver, as we're lovingly calling it now, accomplished in our community. There are a number of issues with the specific how it applies to our area, what things need to be in place, relationships with managed care organizations, and a lot of the ins and outs. All of that to say, Whatcom County is currently working on contracting with a medical and behavioral health entity. And until that contract is in place, it will not be possible for us to get the credentials necessary to do the billing of those functions to Medicaid. So we have had to push our timeline back for this enrollment to middle of next year. So we're moving from cohort 2 now to cohort 3 of jails in Washington State to now look at July 1st of 2026 for being able to get the waiver in place and bill for folks for Medicaid. I just wanted to give you an update. That's really the sum total of it, but it's on the ongoing agenda. So I wanted to touch on that a little bit.
Any questions for Caleb?
Wendy's got her hand up.
Caleb,
Go-
and you may not know because I don't know that anybody knows at this point if changes at the federal level for Medicaid and Medicare, is that going to screw this up?
Yeah, I mean, it's something that we're tracking. So far, there has not been any indication that this would not continue to be a viable solution.
Okay.
But it's anybody's guess, really. So, but yeah, we've seen, so, you know, the state biennium budget has been clarified that it is still an ongoing process for them, and it's funded, at least the aspects of the project that have been funded are continue to be funded. So we haven't seen any huge impacts, but again, we're not in cohort 1 anymore. So we're watching the cohort 1 folks, and we're in communication with them for your awareness. Kitsap County is in cohort 1, and so they've been able to provide us with information of what's going on from their perspective, and helping us to navigate future challenges along those lines.
Okay, other questions for Chief? Go ahead, Dean, go ahead.
I'm just wondering, Caleb, about the connection between this and the process of getting folks pre-release signed up for Medicaid, so that they're on Medicaid at the time of their release. Is there a relationship between this project and that effort?
Yeah, so there's a couple of things to note. Number one, recent legislation at the state level has modified some of the rules regarding who's allowed to maintain Medicaid through a custody in jail. And I believe it's the first 29 days are affected. So it doesn't look, at least according to this new legislation, it doesn't look as though people will automatically be removed from Medicaid enrollment when they're in custody for the first 29 days. So that is a huge positive thing. But as you're pointing out, Dean, this Medicaid reentry waiver is to allow us to continue to enroll people. So functionally, what it looks like is somebody presented for booking. Within 12 hours, we're screening them for either A, eligibility, or B, enrollment in Medicaid. If they're eligible and not enrolled, we can then enroll them or submit an application for that Medicaid, and then that can be connected as soon as it's processed. So even while they're in custody, they can be enrolled, and so that would carry over as long as 90 days in custody, or if they get out within the first 90 days. It would continue to carry over. So it's a bit messy. Again, it's easier for me to say, but that's the intent of this reentry waiver, is to allow people to be enrolled while they're in custody so that they don't lose benefits while they're in custody, and they can also maintain or be enrolled while they're still here.
Okay.
Dr. Wu?
I want to make sure I heard this correctly. Is the primary hiccup the credentialing with the managed care organizations who are administering the Medicaid?
No, no. The primary hiccup for us is Whatcom County, up until the end of this year, has been contracting with Northwest Regional Council for nursing services, and a number of other entities for the behavioral health and medical services within the jail. When we are looking to get services connected with Medicaid and having those reimbursements done here, we have to know who that's going to be. And since we're not going to continue contracting with Northwest Regional Council and others past the end of this year, we had to understand what the entity was going to be for the credentialing that we'd have to apply for through the state to make the billing work. And so now that we know what that agency is going to be, they're going to take over services for us on January 1st. But we still have to get them on board, and we need a little bit of time to get caught up with those services before we can start working the enrollment piece. We don't have staff for it either. There's a couple of other things, Dr. Wu, that we need to have in place. We don't have staff. There's some infrastructure issues that need to be worked out. But that the biggest challenge has been ironing out who's going to be our medical services provider.
Thank you.
Okay, I want to move us along here. Thanks, Brian, for facilitating, and thanks for the presentation, Chief, and to Lieutenant Carb as well. So I'm going to move along here to the next item, and that item is, give me 1 second. It's in packet page 1 and 2 after the schedule that you've received here via email from Jill Nixon. And the next item is item number 4, Division Street Work Group draft recommendations. This is going to be reported by Hannah Fisk from the Health Department. I just wanted to tee this up for Hannah real quick here, and just for the group. So the Behavioral Health Committee has developed 3 different work groups pursuant to the Incarceration Prevention and Reduction Task Force mission. And the 3 work groups are reentry and diversion, and that's headed up by Brian Estes, who's my co-chair. The data group is headed up by Dean White, or convened by Dean White. And then the one that we're going to hear about today is the Division Street Crisis Facilities Work Group. And I convene that one, but I'm just a facilitator. I'm not the Hannah's clearly the expert on this stuff, but it does involve Arlene Feld, Danny Carroll, Hannah Fisk, Stephen Traff, and Tori Sandos. And I wanted to provide so we meet every 2 weeks, and I thought it'd be a good idea to provide this group just kind of a summary draft of what we've been talking about, and we wanted to get some feedback from you all today too. So I just want to turn the floor over to Hannah. We're still doing pretty good on time, and I know that we've got another item after this with Andrew Mitchell from our Muni Court. So I just want to give both presenters enough time to present and answer any questions. So Hannah, are you feeling like you're ready to go? Okay, it's all yours.
Great. I just wanted to start off by appreciating Lieutenant Carbs and Raylene's sharing of their losses, and just express my condolences. I think it's a brave person who can share such great losses and help us learn how to do better as a community. So thank you for sharing, and my deepest thoughts go out to those families. Like Dan said, we do have this work group. It's been really great. It's a really great work group, actually. So many different perspectives, so many different experts from different fields talking, and we get into some really specific details. We wanted to come up with a document that kind of reflects some of those conversations, and we've added lots to it and tried to pare it down. And I have a feeling it's going to go back out again as we kind of circle back around to our hot topics. In the document that you see attached is a kind of more targeted summary of where we're sitting. And again, just know that we have lots of goals and we want lots of things out of this campus, and it's hard to pinpoint what makes the most sense and what's the most feasible. But as you look at it, we kind of start with some behavioral medical services. So we really tried exploring different facilities or build outs, or what we want to be co-located in an area to maximize efficiency and effectiveness of our treatment providers. And so you'll see some things that are familiar, things that are in our justice implementation plan, like a 23-hour facility. And you might see things that aren't really talked about much, like competency restoration services or a 24-hour pharmacy that's really negatively impacting our current treatment providers right now. So those, you can see the whole list. Again, we've had extra things. We really try to speak from our fields and what we know our community is saying is missing, and what makes sense to be at this location versus another site. So we've talked about housing and treatment, housing with treatment supports in place and all of that stuff. And should that be located on a treatment campus, or should it be located in the community with peers or other communities locations? You'll also see that we've spent some time talking about what does this place or this location need to really be as robust as it could be. And so there's things like a central access hub. And we talked, we thought places like NAMI as a really great provider who really brings community together and helps people feel supported and understood. There's other providers out there, but thinking about where families can also go that makes sense, that could help bring people together. We discussed things like animal and childcare needs that prevents people from getting into treatment, and how and if this location should meet that need. So people can actually get the childcare they need to go into their appointments, or provide, more than maybe the 14 days that the Humane Society can offer, so that for cared pets and animals, so that people can go into treatment and know that their animal is taken care of. What we spent some really great time on is this social enterprise and vocational education pathways. So a place for people like second chance employment, a place for social enterprise. So a lot of our conversation has been around also like these are all expensive facilities. And in this day where income and grants and sales tax are down, Tori really was our expert on this, leading this conversation. And I wish she was here right now, but she just has such a wealth of knowledge, but also ways that could be multifaceted. So are there facilities or businesses that could be co-located that could actually generate revenue while also providing employment or vocational opportunities for people who need maybe some more support in getting those experiences underneath their belt. So that's listed there. And that one, I feel like we're really going to flesh out more, but it has a placeholder. And again, we've talked about funding and sustainability and what makes sense. And we had a longer list and we kind of took it off because we're just still waiting for more information, some data to come in to really get a better idea of what that looks like or what we need in order to feel more informed moving forward. We've also talked a lot about legislative advocacy, policy advocacy, and that's been really important. And that's not on here because I think we need to look into it a little bit more. And I think though that that's a hot topic that we want to address here is kind of going, if we go above, if we say, hey, we want to build out these structures or really support this work, what do we need to advocate for on a broader level to make it happen? Because it kind of starts there, right? That seems to be where we get stuck sometimes, and it's what makes things possible. So we have some things that we still need to do. We're still looking at data. We're still asking for some reports to come in to really help inform the final recommendation and what we're thinking about. But we just really wanted to bring forth like where we're at and our thoughts. And again, like we always want to hear from you all. So any advice or input, or have you considered this? We are open and would like to hear your thoughts.
Thanks, Hannah. Hey, Hannah, can you put up the document on the screen real quick, just so people can have just a visual on it, just
Yeah.
just for a minute or two. I mean, it's kind of dense. I don't want to go into the whole thing, but Hannah did a really good job at summarizing the basics, the vision and guiding principles and behavioral health supports and such. Dr. Wu, you have a question? Go ahead.
Yeah, just a comment. First of all, thanks for the presentation and for the document. I found them both really, really informative. I just happen to know that in Seattle, there's an animal shelter which does long-term fosters for this exact situation. I don't know if that's something that we have locally or could be developed.
Yeah, so the Whatcom Humane Society is literally like a block down the road from 2030 division. So there could be an opportunity to partner with them. And then just one other point I wanted to make, the city purchased a fair amount of land directly behind the Division Street facility, and we intend to put trails, the Bay to Baker trail through there. So there might be some opportunities for, people to take their pets out and go dog walking or some outdoor therapeutic opportunities as well. Brian Estes, go ahead.
Yeah, I have a couple questions. I guess first, kind of related to funding going forward. Is anything at Division Street going to be paid for from the jail tax? And also, how would you characterize the behavioral care center which I assume is located on the Bounty, with some of the services are going to be provided at Division Street?
That's a great question, Brian. Dan, do you want me to take that one or you?
You take the first part of it. I'll take the. Go ahead.
When it comes to the jail or the Justice Project levy, there could easily be some overlap. There is, right, some dedicated dollars to behavioral health as it relates to the justice implementation, and judicial kind of segment of that. It's unclear exactly, how much that will be or what that will look like. And so I think that we'll just have to wait and see. But I definitely think it's a funding source that we're looking at. And as far as the location of the behavioral care center, I think that that's something that's up in discussion. And so we're actively talking about that. And any partnership with it, if it's located out La Bounty, would have to be closely tied to this campus, as we can all imagine. Yeah.
Yeah, I think Hannah covered it pretty well. I would say that at this point, not everything's on the table, but I think that we do need to consider where the behavioral care center would be located. Do we want to do an in-custody center at La Bounty, or do we want to do an out-of-custody center at Division? I think that's something that we're talking about, and that's something that we want feedback on too. The BCC work group has not concluded, but the recommendation from them is that it be located at Division. So there was like a more full behavioral health campus that would include the 23-hour center, the Dequal Each folks, and the Ann Deacon Center, and perhaps a medical center and pharmacy that was brought up in the slide that Hannah just shared. So any feedback would be helpful at this point. We continue to meet, and we want to make a recommendation to this committee, and then move it upstream to the task force, and eventually to county council, so we can make or they can make decisions. Go ahead, Brian.
So moving this forward would require a motion by this joint committee or just behavioral health committee to adopt these recommendations. Is that how you see the process going forward?
Yeah, I don't know that we're quite there yet. We wanted to take this opportunity to get some feedback from the group here, or the groups, I guess, the two committees. I mean, since we're together today, if we could get feedback, and then we can go back into the work group, and then we can then bring back more of a semi-finalized set of recommendations. Um, so anyway, that was the thinking to bring it together. Dr. Wu, go ahead, and then Brian.
In terms of scope, isn't it true that 50% of the revenue from that tax is for treatment as opposed to jail facilities and operations?
I can tell you what the city committed to. The city committed to that scope of funding once the down payment for the facilities has been completed with the city's portion. So yes, at some point, I would say I wouldn't say out years, but I would say within a reasonable amount of time, which I would say might be 3 to 4 years. The city's portion would heavily favor behavioral health funding, and that's a commitment that the previous administration made. And I don't want to speak for the current administration, but it's my understanding that that is the tone and tenor of the city. If that answers your question.
Thank you.
Okay, thanks, Dr. Wu. Brian, go ahead.
So I have a suggestion for 3A, and I think it would be worth explaining some of these services or facilities in a little bit more detail. For example, to contrast a 23-hour crisis stabilization facility with psychiatric urgent care. How are they different? And also, I would mention in context, what's there right now. We have the Ann Deacon Center, we have Diswalik. I mean, it's sort of a plan for a campus, in other words. So I would just put this, I think it would help people understand this better if there was a little bit more, context and background to what we're talking about. And if there was some sense of what capital facilities would we need to build there to do a number of these things? So does that make sense in terms of, what exists today, what we aspire to, and maybe some notion of the capital project, nature of these improvements or services?
Sure. And thanks, Brian. And that's exactly the kind of feedback that we're seeking here today is we want to understand what do we need to do? What's next on the list here that we need to define better? So thank you for that. I'm just taking notes here. Raylene, go ahead.
And just to echo a little bit what Brian said, it would be nice to have the comparisons between the Ann Deacon Center and the vision for this 23-hour service. So for example, Ann Deacon Center, they can't go hands-on with anybody. Is that something that will be able to happen with the 23-hour service clinic? I mean, there's a lot of things that people can't get in there for. They get turned away because of certain diagnoses. And so envisioning something else seems like we should say, well, this is what Ann Deacon Center can't do. This is what the 23-hour services does do. To have those side-by-side comparisons, I think would be beneficial.
Okay.
Thanks.
Okay, thanks. I'm just taking notes here. And I see Lieutenant Nelson from BPD here on the call too. And one of the things that we want to query our first responders is, what's your ideal drop-off time? What does that look like? And what do you need to see in a facility for if they don't have a ITA, Ricky's Law, that kind of thing. If they're not have that, if they don't have that as part of their policies, then what does that mean for our law enforcement and our first responders? So, Brian, you have another question?
I just think it would be helpful to differentiate between voluntary and involuntary commitment, or are any of these facilities going to take involuntary, detentions?
Good question, and we'll make a note of that. So Compass does short-term ITAs right now. Pioneer does not. And so that's Ann Deacon Center. That's the two sides of the house. And if we're talking a BCC, what does that mean when it comes to ITAs? The 23-hour center is very unclear to me because it is one day basically. So what does that mean for an ITA? I don't know. Hannah, do you have any? Go ahead.
Yeah, just clarification. None of the things listed on this document are under the scope of ITA. So we would need a SWIMS or an ENT facility or something like One Central. It doesn't mean that couldn't be added to the list. I've been in communication with Peace Health about, their involuntary side of One Central. So it's definitely up there, Brian, if you're advocating for it. But none of these facilities would do involuntary holds. The 23-hour does have an exception to that, where when we went and toured facilities that have this license, they typically had a room or two where they could hold until a DCR arrived on site if they felt like someone was at imminent risk of harm to self or others. So they have a clause in there, or the ability under the license. So that would be something worth exploring, but it's not technically a facility for holding beyond that initial investigation.
Okay.
One of the comments that I think came out of our discussion previously, this was maybe just the Behavioral Health Committee related to the King County Auditor's evaluation of jail health services. I think there are benefits for having a lot of your providers and staff be Whatcom County employees versus being contracted out. This document may not be the place to bring that up, but I think going forward, that's something we need to consider with the new jail and behavioral health center. But it's something that I think might be mentioned here in terms of some of the benefits. Whatcom County typically doesn't do that, but I think they should consider it going forward.
Thanks, Brian. LT Nelson.
Yeah, I just wanted to speak towards that 23-hour facility. I think Hannah touched on quite a bit, but from the law enforcement and legal standpoint, there's some language in there about involuntarily taking a person for 23 hours. That is not something that at least our agency and city attorney is prepared to do. It would be a real distinction from an ITA opposed to taking somebody to that 23-hour facility. So I would certainly not look at that as an involuntary option for law enforcement.
Okay. Thanks for that input. Appreciate that. Dean, go ahead.
So just want to mention that, in addition to the work group or the team that Hannah has just reported about, there's also a 23-hour facility team that's been looking at all of the issues around how do we make, what is that facility? What should it be? We've gotten a lot of feedback. Hannah is staffing both of these groups, I think, and so the question of how does the 23-hour care facility relate to other things on that campus or elsewhere is very much, on the table with that 23-hour facility work group. And some of it has to do with, are there economies of scale that can be realized by integrating two or more of those functions into one operation? For example, a 23-hour facility really refers to the process of having a set of recliner chairs in a space to which people can be in which people can be placed. And psychiatric urgent care refers to the kind of services that people might need both in those chairs and others who walk in. So, there's a lot of potential crossover or overlap or integration that I think requires further exploration.
Thanks, Dean. Just making notes here. Alexis?
Hey there, I kind of just wanted to speak momentarily a bit into contrast to what Brian had contributed regarding moving towards utilizing county staff to support the services versus a contract with local services. I think given the current legislative climate and everyone's waiting to see what happens. And in addition to that, continuity of care for individuals that are engaging in these services, I think would be best served if we kept it on a contract basis. So they are familiar with the different organizations, the people within those organizations would likely align more with a trauma-informed care approach as opposed to keeping it county staff and then them not engaging once things progress and them transitioning to another provider, in other words.
Okay. Okay, thank you. Thanks. That's really good feedback. Thank you. Taking pages of notes here. Okay, any other thoughts? We do need to move on here. We're at 12:39. We do have a presentation from Andrew Mitchell from courts. I want to make sure we give him enough time and for you to ask questions. Anything else on this? And we're going to come back too. This isn't the end of the discussion. We're going to come back and synthesize these notes, integrate them into the thinking, and then come back to you before we make a recommendation to the committee. So anything else here for this item? Okay, seeing none, I'm going to go ahead and turn it over to Andrew Mitchell. Raylene, is it okay if I just introduce? Okay, I know we're just kind of running short on time. I just want to make it smooth. Andrew, the floor is yours.
All right. Well, I'll do my best. I haven't really had a whole lot of time to do a whole presentation. So I'll give you the short story here. We're running a therapeutic court here at the Bellingham Municipal. It's a community court program, which is an alternative to your standard court tract. When defendants get a citation or a ticket, they have an opportunity at arraignment to enter into this program if the city prosecutor deems them fit for the program. What we're doing right now is we're creating case plans for people to hit short-term, long-term goals. And I'm sorry, I guess I should have led with the benefit of being in the community court is your charges are dismissed with prejudice and your fines are forgiven. So there is some, incentive for them to take this tract. But yeah, we're very new. We started in March. I'm sorry, I was trying to be on a little bit sooner today. We had our community court this morning, and I've been pretty much in there since 8 o'clock. So we had 9 people on today, 4 people joining, and yeah, it took a little bit. We're still kind of figuring out how our case plans work and what types of services we need to get them into, and what they're responding to. So maybe that was a little bit too much information at once. Is anyone unfamiliar with the court process or therapeutic courts? Anything I could expand on?
Raylene, go ahead.
Andrew, thank you so much for your presentation. I know some of us here all know what dismiss with prejudice means, but this is also for the public. So could you explain the difference from a dismissal with prejudice to a dismissal without prejudice, and that the charges are still filed? Thank you.
Yeah. So when charges are dismissed with prejudice, that means that the city can't refile the charge. When they're without prejudice, they're pretty much being held until the city has enough probable cause or evidence to continue with the case. So this would mean that their charge is gone completely, so they can't bring that back. And yeah.
Other questions for Andrew? I've got maybe a couple here, but
yeah.
Oh, go ahead, Bertie. I think you're muted.
I just have a quick question, which is fairly basic.
Yeah.
What's the criteria for people being able to be referred to the therapeutic court? I mean, who is eligible?
Well, I think right now that's kind of up to our city prosecutor. I know that he's kind of limiting. Ryan Anderson is our city prosecutor here, and he's looking for, from what I can tell, nonviolent. So not any domestic violence charges. He's going into their criminal history and kind of applying his, I would think, the city's filter, and then looking for potential candidates that would succeed because they have to want to be in the program. It's something they volunteer to do. So really, he can get referrals from anywhere. It's not like the LEAD program where there's a quorum that votes for people to be referred. It's basically if you think that you'd be a good candidate, we're trying to shine a little more light onto the specific requirements for it. But right now, it's pretty much low-level misdemeanor, nonviolent defendants.
Got it.
Yeah.
Brian?
Yeah, I had a couple of questions. What's the duration of the court for the individuals, and what kind of support or relationships do you have with maybe providers to do some follow through once they're in the program?
Yeah, so right now we started doing 3-month programs, and it I think only 4 or 5 of our first participants really got in those short tracks, and we realized it wasn't really addressing, we needed more time. So right now our tracks are minimum 6 months. It could be up to 2 years, but so far 6 months is kind of what we've landed on. Other when we develop the case plans for that individual, we try to connect them with services, and depending on what they might need. We don't have the manpower right now or the financial well-being to provide case management to individuals, but we do have a contract with probation services over at District. So we actually have them report to probation to be monitored, which could mean as simple as checking in before their next court date. Or if they have been asked to do things with their case plan, like complete a online theft awareness class, check in with Dija Walich and get a mental health evaluation, comply with treatment, clinical treatment that they recommend, or go down to Evergreen, Goodwill, get your resume going, check in with WorkSource for job opportunities or training, or hit the opportunity council to put on the wait list. Even Roads to Homes, really any service provider that we feel is somehow going to be beneficial for them, we kind of write it into the case plan specifically. And we'll try to do our best to invite those service providers when we know that they're coming in for their community court date. The difficulty is that they don't always show up when we want them to, and sometimes I know I feel bad when service providers sit all day and a defendant doesn't show up after a few hours. So sending them to their facilities works, and also having probation doing the check-ins, and they can also check in with me. We actually have a great relationship, so we do our best to communicate where they're at, and then we're also learning how to communicate since we don't have gelada or DCCM. I know that probation uses enterprise justice to communicate, and we're not going to be onboarded with that until the state rolls it out to the municipal court and the district court next year in October. So that way we can share notes directly rather than just phone calls and emails, which is what we're currently doing.
Can you explain what those acronyms you refer to mean?
The software acronyms for
Yeah, I mean, they're just the general concept of it's information sharing, or can you explain?
yeah,
a little
it's
bit more?
they're just different types of applications that different departments use.
Looks like Andrew froze up here. Am I the only one seeing that, or?
No, if he can try to refresh, if he can hear us.
Yeah, Andrew, we can't hear you. Okay.
Do we want
Someone
to?
message him?
Software.
Oh, there we
Oh,
there. Hey, Andrew, you froze up there for about 25 seconds.
Oh, great. Yeah, that sounds like my internet here.
Okay. Do you want to just maybe recap what you just had mentioned over the last 30 seconds?
Yeah, sorry, I didn't mean to get so in depth with acronyms. Basically, those are all just different types of software that different departments use, and we just we don't all have the same stuff right now, so we're just using notes to communicate. I'm not sure how long I talked there.
No, I think that probably summarizes it pretty well. Raylene, did you have a question?
Yeah, I'm just curious, is the community court grant funded? And how many participants are needed to operate this? I mean, you mentioned there's a contract with probation and prosecutors involved. I'm assuming a defense attorney. Are you dedicated to just the community court yourself? Like, I'm looking at, costs to run this.
Oh yeah, so this isn't operated solely on a contract. It's part of the Bellingham Municipal Court. We also have we have arraignments here, pre-trials here, motion hearings. There's the district court runs kind of their wellness court here on Tuesdays as well. But this community court is part of our basically just part of our municipal court operations. I do receive funding to help basically provide for the therapeutic courts. My job right now is the acting court services manager, so I'm trying to maintain connection with the administrative office of the courts to continue to get our state funding every year that helps us provide things like payment to therapeutic services, basically anything that we might need to help set up our community court and provide basic needs for folks, graduation gifts, really anything that we can spend our money on to help strengthen our program. But it'll always be here. It's not solely dependent on the contract funding at all.
Okay, other questions for Andrew? Dean, I wanted to address something that you had brought up maybe almost an hour ago regarding the commitment for behavioral health dollars for the, or maybe it was Brian, I can't remember, for the jail tax. It's really a justice tax. That's how I would characterize it. So I just want to just set the tone here for the direction of the city and where we're going. And so council just approved, I think it was $320,000 over an 18-month period for the alternate response team. It's probably like maybe like 3 months ago, 3 months ago. The community court was envisioned after the council and the previous, pardon me, administration uh, made public drug use a misdemeanor that was later followed by the state that made it made possession a gross misdemeanor. And so I just want to address these, just kind of the direction that the city, I'm not speaking for the county here, but the city is going when it comes to therapeutic courts like the wellness court that Mr. Mitchell just brought up, the community court that took a while to get off the deck, but it's now operating, the ART, the GRACE program, the LEAD program, all these things work in concert with our law enforcement and our first responders and fire, because the shift has been over the course of the last, I don't know, 10 years or more, from moving away from just purely incarcerating people to making sure that people have options. And I wanted to note that one of the other work groups that we have from the Behavioral Health Committee is a reentry and diversion group. And so I think it's important that we recognize that that's the direction that we're going. And I'm happy to answer any questions about that as a policy and lawmaker. And also to get any feedback from you all, if you have any, on just that direction that the city's going.
Thank you for that, Dan. I think one of the things that we're all facing is if we're looking at these diversion programs, housing is one of the key necessities to move forward on this. And I know, the county's still working on grant funding for additional housing, but until we can get that, some of the diversion programs don't have the gusto that is necessary because of that. But I think that's where we need to put some of our focus under legislative needs.
Okay. Good. Okay. Thanks, Raylene. I appreciate that. Housing always comes up. That always comes back to housing, lack of housing stability, basically, is what is a primary cause of people recidivizing or getting, facing first charges. So thank you for that, Raylene. Any other thoughts real quick here? We're approaching time. I want to make sure that we respect everyone's schedules today, and we do need to take public comment. I see that there are, does anyone have any further business for today, or anything that we need to put on the agenda for the next meeting, either of behavioral health or law and justice? Go ahead, Brian.
So I am a member of the advisory board of the North Sound, Behavioral Health ASO, and they brought up that Lummi is in the process of developing their own DCRs, designated crisis responders. And since they're an independent nation, it'd be very interesting to see how they structure this. And at some point in the future, when that program is more fully developed, I think it would be very interesting to have them present to this group about what their model is for example, who can make decisions like that. And the whole ITA issue is going to be, in my view, the legislature needs to address this, and there will be reform at some point, I believe. But anyway, I just wanted to note that as a potential future agenda item.
Okay. No, thanks for saying that. And then one other piece is I'd like to invite folks from the Swinomish, from the DeGualich Clinic at some point at a joint meeting. I think that'd be appropriate at our next one. We do these 4 times a year. Cedric, go ahead.
Just really quick, I'm hoping maybe we can get the data work group on the agenda, at least for the next BH committee meeting. I just wanted to give a 30-second update if I can. We presented our proposal, actually Bertie Safford presented our proposal to the overall IPRTF to encourage the county to hire a staff person to carry out the goals of the Village Reach program. That was something this group had voted on previously. I think there was maybe not enough time for them to discuss. There was some hesitation. We've discussed in our data work group amending the wording of the recommendation a little bit. to be less specific about where that position reports, but really just emphasizing that they have sufficient authority and skill set to oversee and carry out this work. So we'd love to give a more detailed update in the future. We'll probably have more developments by the next time we meet.
Okay. Thanks, Cedric. Yes, let's absolutely do that for sure.
Great, thanks.
We'll do it. Okay. Just made a note of that. And then, okay, Jill, let's see here. It looks like we've got 3 people attending. Just want to open this up for any opportunity for public comment.
Any of our attendees would like to speak to the committees, please virtually raise your hand now. No hands are raised, and I don't see anyone in our conference room.
Okay. All right, sounds good. Anything else for today, folks? All right, well, thanks. This was a good joint meeting between the two committees. We're at 12:56, so I'm getting up 12:57, so I'm getting you out of here with 3 minutes to spare. Lieutenant Nelson, go ahead. Sorry.
Oh, sorry. I was going to give you claps and I got the wrong emoji.
Oh, no.
Hey, I just wondered, Wendy, could you stay on the call for a second? I just wanted to chat with you about something.
Yeah. Okay. I'll stay on too because I want to talk to Wendy as well. Otherwise, we are good to go. Thanks, and this meeting's adjourned. Thank you.